For the sake of time, we have to move to this important session. It is about the acute heart failure, and it's my pleasure and honor to introduce the first speaker, Professor Laila Abed from Tunisia. She is a professor of cardiology and head of the department in EGYHF. I hope I pronounced it right, and Safakis University. Yeah. Professor Laila.
Thank you. Good afternoon, everybody. First of all, I'd like to thank Professor Magdi Abdelhamid and Professor Islam Shouqi for this kind invitation and for this wonderful meeting in a very, very nice region as well, to talk about how to assess congestion in acute heart failure. So, as you know, that congestion is responsible of recurrent hospitalization, accelerating disease progression, and worsening the prognosis. So, the evaluation of the congestion severity, monitoring its course during treatment, its early detection of subclinical congestion after discharge are very, very important in our clinical practice. So, how should we evaluate congestion in acute heart failure? Patients presenting with acute heart failure have clinical signs, symptoms related to congestion, such as dyspnea during exercise, orthopnea, fatigue, reduced exercise tolerance. They have physical signs of congestion, such as jugular vein distension, peripheral edema, rales, or third heart sound. But, however, these signs and these symptoms are poor correlated with congestion, and their sensitivities range between 46% and 73%. So we need other tools. We need echocardiography to evaluate congestion in acute heart failure. And you know that echocardiography has a crucial role in the diagnosis of heart failure, providing structural and functional information, and especially to evaluate congestion. Especially in the acute setting of acute heart failure, echocardiography offers us a quick point of care examination by providing valuable information about left ventricle systolic and diastolic function, but especially it offers us a non-invasively estimate of cardiac filling pressure, the left ventricle filling pressure and pulmonary congestion, but also the right ventricle filling pressure and systemic congestion. So how do we evaluate left ventricle filling pressure and pulmonary congestion? We have 4 key echocardiographic parameters. We have mitral inflow velocity and EA ratio. We have also E prime mitral ratio. We have the third parameter, peak tricuspid regurgitation velocity, and the fourth one is the left atrial maximal volume index. These parameters were validated in case of chronic heart failure. But what about acute heart failure? The E prime is widely used for the estimation of left ventricle filling pressure and is correlated with invasive measurement of left ventricle filling pressure. The same case is for the average E to E prime ratio, with the average of 14 is indicative of elevated left ventricle filling pressure. So these parameters are validated in case of acute heart failure, but in some studies we find that the ratio E to E prime, the cutoff is about 20, higher than the chronic heart failure. The second parameter is peak tricuspid regurgitation velocity and systolic pulmonary artery pressure estimation, and peak tricuspid regurgitation jet velocity more than 2.8 is strongly indicative of elevated filling pressure, and it allows us to estimate systolic pulmonary artery pressure, and when it's more than 35 millimeter mercury, it's a criteria for estimating high left ventricle pressure. But you know, in practice, in our clinical practice, sometimes we cannot have tricuspid regurgitation jet. So we need another tool to evaluate systolic pulmonary artery pressure. And we have the short pulmonary artery acceleration time. When it is lower than 100, it's an alternative parameter to indicative of systolic pulmonary artery pressure elevation. And in practice, it can help us to evaluate systolic pulmonary artery pressure. Another very interesting parameter is the left atrial maximum volume index. But you know that left atrial enlargement is a consequence of the chronic effect of a long-term increase of left ventricle filling pressure. And we should measure it by the biplane disc summation technique. And if it's more than 34, we have an enlargement of left atrium. And you should pay attention that left atrium enlargement has several limitations. It doesn't reflect the instantaneous pressure change in a case of acute heart failure, and it has a low sensitivity for the detection of early elevation of left ventricle filling pressure. So it isn't very interesting to evaluate left ventricle pressure in case of acute heart failure, but it's a direct sign for a chronic elevation of left ventricle filling pressure. So, based on these 4 parameters, the European Association of Cardiovascular Imaging, joined to the American Society of Echocardiography, proposed an algorithm to estimate the left ventricular pressure in case of depressed left ventricular ejection fraction, or in case of myocardial disease with normal left ventricular ejection fraction. And this algorithm is based on the mitral flow, as you say. And then if we have mitral flow, the ratio E to A more than 2, we could conclude to the high left ventricle filling pressure. It's easy in case of restrictive pattern of mitral inflow. But in the other case, when we have a ratio EA less than 0.8 and E velocity less than 50 centimeters per second, we have normal left ventricle filling pressure. For the value in between here, we should add 3 other criteria. The average of EI prime more than 14, the tricuspid regurgitation velocity more than 2.8, the left atrium volume index more than 44 milliliter per meter square. In this case, it's easy if we have 2 positive, we have high left ventricular pressure. 2 negative, left ventricular filling pressure are normal. But in the situation where we have only 2 criteria, but they are discordant, 1 positive and 1 negative, we need further parameters to evaluate left ventricle function. So we will need the left atrial peak systolic strain. You know that the increased resistance to filling alter the atrial function before left atrial dilation. So in case of acute heart failure, we can have altering of function of left atrium before dilating of left atrium. And you know that the function, not only the structure, the function of left atrium can be assessed by speckle tracking, by 2D echocardiography, by strain. So we have the left atrial peak strain, systolic strain, which evaluate the reservoir function of the left atrium, and studies show that this parameter is correlated to the increasing of filling pressure, and they proposed a cutoff less than 18% for the diagnosis of increased filling pressure. So it's another parameter that helps us to evaluate left ventricle filling pressure. And if we look to this new expert consensus document of the European Association of Cardiovascular Imaging to evaluate left ventricle filling pressure, they add this parameter to the 4 classic one to evaluate left ventricle filling pressure, and they update the algorithm to evaluate filling pressure and congest pulmonary, especially in the situation when we have they have discord between 2 criteria in this situation, and we need the left atrial reservoir strain, and as I said, if the cutoff is less than 18%, we conclude to elevated filling pressure. This algorithm is validated in case of chronic heart failure. Some studies validate these parameters in case of acute heart failure, but we need a more large study. The first step is to evaluate left ventricle filling pressure in case of acute heart failure, but you need to evaluate also the right ventricle filling pressure and systemic congestion in case of acute heart failure. And the famous parameter that allows us to evaluate right ventricle filling pressure is the inferior vena cava diameter with its respiratory changes, and it's an non-invasive parameter, widely used, as I said, for the estimated of right-sided filling pressure. And when it is less than 21 millimeter, the pressure are normally, especially we look to the collapsibility index. When it is more than 50%, it's in favor of the normality of right atrial pressure. Pay attention, in case of mechanically ventilated patients, there is a weak relationship. We can't rely on inferior vena cava diameters. And in case of young persons, as you said, in our practice, young patients have dilated inferior vena cava, but the collapsibility index is normal in young patients. So when we evaluate congestion in acute heart failure setting, we should look also not only to the left ventricle, but also to the right ventricle, especially to the inferior vena cava. And if it is possible, we could evaluate also the Doppler flow in hepatic veins. And if we can find the predominant diastolic forward flow, as you say here, the inversion of the flow S and D, and in the advanced stage, we will have an atrial flow reversed, as you say here. So, as I said, we should evaluate the filling pressure of left ventricle, right ventricle, but what about pulmonary congestion in acute heart failure? Chest radiography, it's a classic exam that we do for our patients with acute heart failure, but the sensitivity are of 57% and specificity for only 89%. And however, he depicts only the more advanced form of acute heart failure and acute congestive heart failure. So we need another tools, very interesting tools, the lung ultrasound, which has emerged as a non-invasive imaging biomarker of pulmonary congestion with diagnosis, monitoring, therapeutic, and prognosis value. It shows vertical B lines, and we should explore all zones to the lung to detect this lung congestion. You will have tomorrow a nice presentation about lung ultrasound presented by my Dr. Hatem Suleiman. Here you see an example of line B. This is the pleural effusion, and here the line B. So ultrasound is sample, is non-invasive rapid method of sensing lung congestion, and the presence of B lines help us to differentiate acute heart failure from non-cardiac causes of dyspnea with high sensitivity of 94, and a high specificity of 92%. But there is a limitation. B line aren't specific for pulmonary congestion because we can find them in case of interstitial syndrome such as COVID-19, interstitial pneumonia, or in case of fibrosis. So in some cases, we need to combine the multiple clinical, laboratory, and imaging parameters to evaluate congestion in heart failure. And guidelines recommend an integrative evaluation of congestive heart failure in acute heart failure, clinical examination, echocardiography, as I said, and also vascular congestion based on inferior vena cava dimension. What about biomarkers? We know that especially natriuretic peptides are very useful tools for the diagnosis of heart failure, chronic heart failure, acute heart failure, but useful tool to evaluate congestion in acute heart failure setting, and they are the mirror of the severity of the congestion. The high the NT-P levels, the severity is the congestion of the patient. And natriuretic peptides help us to detect very early stage of congestion in heart failure. And there is many cutoff proposed by the guidelines, relying on the type acute or chronic heart failure. But pay attention for NT-proBNP. The cutoff change based on the age, based on the renal function, atrial fibrillation, and I'd like to emphasize on the fact that there is a disproportionate correlation between NT-proBNP and the obesity. That's why we are recommendation lower the cutoff levels by 50% in case of obesity. Troponin is this biomarker interesting for the diagnosis of heart failure congestion. In practice, he's very helpful to exclude acute coronary syndrome, but it can be high in case of heart failure congestion due to myocardial stress. There is many hopeful data promoting data about new biomarkers of cardiac origin, but we need large studies to assign the place of this biomarker in the diagnosis of acute congestion. I conclude by talking about the non-invasive hemodynamic evaluation, impedancemetry. We have this tool in SFAX.
Sorry, we have, for the sake of time.
It's the last slide. And you have this tool to evaluate the congestion. It's non-invasive tool, and we are conducted a study to study the correlation between echocardiography and impedancemetry to evaluate acute heart failure congestion. I conclude by saying that establishing presence of congestion at an early stage is essential for proper management of patients with acute heart failure. Clinical evaluation of congestion, natriuretic peptides and chest X-ray play an important role in management, but the addition of echocardiography is helpful. Lung ultrasound is a new and most welcome tool with high sensitivity for pulmonary edema and has proven valuable in the diagnostic and prognostic assessment of acute heart failure. My key message is that the evaluation of congestion in heart failure implies a comprehensive multi-parametric approach using imaging and the circulating biomarker. Thank you for your attention. Okay.
First of all, you are welcome in Egypt and Aswan Nawarit. Thank you for your comprehensive lecture. I'd like to ask a small question. Do you prefer to start with all modalities to assess congestion in the patient, or you can be satisfied with, for example, echo as a simple tool for initial assessment, and then go to sonar or biomarkers in other patients or some situations?
Thank you for your question. I think that echocardiography is an important tool to diagnose heart congestion. It depends on the clinical status of the patient. It depends also on the disponibility of natriuretic peptides. I don't know if in your practice, especially for public centers, it's easy to have natriuretic peptides for your patients. So echocardiography in cardiologic center is available. We can begin with simple parameters such as mitral flow, and after that it depends on left ventricle ejection fraction, because sometimes if we have a restrictive profile with decreased left ventricle ejection fraction, it's easy to conclude to a high left ventricle filling pressure. But sometimes in intermediate situation, it's difficult to conclude, so we need further parameters to conclude about heart failure congestion.
Thank you very much.
Thank you, Dr. Laila, Professor Laila Abid. For sake of time, because there is a lot of questions, but we'll make it late. It's my pleasure to introduce Professor Ahmed Tag, a professor of cardiology from Suez Canal, and he will speak about treatment from ER until re-discharge. Okay.
Bismillah ar-Rahman ar-Rahim. Thank you for the introduction, and I'd like to thank Professor Magdi Abdelhamid for his enthusiasm and actually very high caliber meeting. My presentation is acute heart failure treatment from ER until discharge, and I have some comments from my colleagues early in the morning that it's very lengthy title, but I'll try to make it as short as possible. Heart failure is a big growing epidemic worldwide with increasing prevalence, incidence, and incidental cases worldwide, either heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. There are lots of ugly faces of heart failure. Number one, killer actually worldwide. More than 20 million now having heart failure, and this is stated by CDC at 2017, I think. Economic burden, very high economic burden, significant mortality, morbidity, hospitalization, rehospitalization. It's actually significant disease burden. Heart failure pathophysiology, all mechanisms of heart failure will lead at the end of the day to ATP depletion, ischemia, oxidative stress, which will do some sort of mechanical, functional, and actually molecular changes, neurohormonal changes, which will end up with either heart failure with reduced ejection fraction or with preserved ejection fraction. Generally speaking, when we speak about management of acute heart failure according to the guidelines of the European Society of Cardiology 2021, the important step initially when we assess a patient with suspected acute heart failure is to exclude two important, might be killing mechanisms. Exclude cardiopulmonary instability, like massive pulmonary embolism, for example, cardiogenic shock, and the exclusion of high-risk acute coronary syndromes. Because if we exclude those causes, we can manage heart failure accordingly. If we didn't, we have to manage accordingly as well. Then we have to diagnose and treat at the same time, because sometimes time means muscle, even in acute heart failure, then reassessment and re-evaluation. Those are the main presentations of acute heart failure. Acutely decompensated heart failure involving mainly LV dysfunction, and usually the patient is wet and warm or wet and cold, and the basic management criteria for those patients: diuretics, inotropics, vasopressors, short-term mechanical circulatory support. Another presentation is acute pulmonary edema, and this increased after or predominant LV diastolic dysfunction with possible presence of valvular heart disease. And usually this could be sorted effectively with diuretics and vasodilators. Then we have isolated right ventricular failure, and I think my colleague Professor Karim Saeed spoke about that. And for those patients, we have RV dysfunction, and we can use diuretics to peripheral congestion, then inotropics, vasopressors, and sometimes mechanical circulatory support as well. Then severe cardiac dysfunction, cardiogenic shock, and this will need inotropics, short-term mechanical circulatory support, or renal replacement therapy. So initially, we have to work to exclude important other mechanisms of presentations of acute heart failure, like cardiopulmonary catastrophes, like severe massive pulmonary embolism or cardiogenic shock, then to exclude acute coronary syndromes, then we have to go according to these algorithms. Of course, sometimes we don't have time to do that, but we have to do that. While we are managing the patient, we have to do, the most of those, like including ECG, lab workup, PNP, echo, ECG, and of course, chest X-ray if possible. Management of patients with suspected acute heart failure. Initially, we have to make sure whether there is cardiogenic shock and respiratory failure or not, because if we have cardiogenic shock, we have to be ready with pharmacological support, ventilatory support, and mechanical circulatory support. If we don't have, we have to identify those important sham PET, including acute coronary syndromes, hypertensive emergency, arrhythmia, mechanical causes like VSR or acute mitral regurgitation, for example, pulmonary embolism, infections, and tamponade. If we have any of them, we have to manage accordingly. If we don't have, we have to go further. Management of patients with pulmonary edema, initially oxygen is class 1 recommendation with or without ventilatory support, class 2A. If we have systolic blood pressure more than 110, then okay, we don't have cardiogenic shock. So if we have signs of hypotension, we have to use loop diuretics. If we don't have, again, we have to use loop diuretics as class 1. If blood pressure is more than 110, we can use loop diuretics and vasodilators. If congestion is relieved, we have to initiate medical therapy, and I will explain in a few minutes. If not, we have to consider mechanical circulatory support, renal replacement therapy, as you see here. What about if we have isolated right ventricular failure? We have to exclude acute coronary syndrome, of course. If we have any, we have to go, especially for primary PCI if we can, or management accordingly. If we don't have, we have to optimize fluid status, which is very important. If we have marked congestion, then loop diuretics. If we don't have, we have to consider careful fluid administration. If we have peripheral hyperperfusion, persistent hypotension, we have to go for vasopressors or inotropes. So if relief of signs and symptoms is accomplished, we have to do follow-up. If not, we have to go for further destination therapy like RVAD. I know it's not available in all centers, but it's one of the important options. What about patients with cardiogenic shock? Again, we have to exclude any mechanical complications or acute coronary syndromes. So if we don't have any, we have to identify which type, and we have to go for oxygenation, considering inotropes or vasodilators or mechanical circulatory support. Of course, class 1 recommendation is oxygenation or ventilatory support. If symptoms improvement, so we can assess etiological causes and manage accordingly. If not, again, we can go for mechanical circulatory support. Management of diuretic therapy, and this is very important because sometimes in patients with acute heart failure, we give plenty of IV diuretics, and we don't count for the comorbidities which could be done by diuretics themselves, including renal impairment and electrolyte dysfunction, electrolyte imbalance. So if the patient is on oral loop diuretics, we can shift to IV. If not, we can increase the dose of furosemide, and we have to consider urine spot sodium and urine output. That's very important. If urine output is satisfactory, so we have to repeat similar doses. If not, we can double the dose. So if this is already accomplished, that's fine. If not, we can use combination therapy. We have to check, of course, serum creatinine, potassium, and electrolytes each 12 hours to 24 hours. Those are the main inotropes which could be used and vasopressors in patients with acute heart failure. Of course, I will not go through them, but all of them, I think, are available in our CCU. And this is the recommendation for initial management according to the European Society of Cardiology guidelines. Oxygenation or oxygen is recommended in patients with saturation less than 90% or PaO2 less than 60 millimeter mercury. And this is class 1 recommendation. Mechanical intubation is recommended for progressive respiratory failure. Otherwise, we might lose the patient. Non-invasive positive pressure ventilation should be considered in patients with respiratory distress as class 2A indication. What about diuretics? Diuretics are important tool of management in patients with acute heart failure, and this is class 1 recommendation to use intravenous loop diuretics recommended for acute heart failure to relieve symptoms. And it's class 2A to combine loop diuretics with thiazide type diuretics should be considered in resistant edema or patients who are not responding to loop diuretics. What about vasodilators? It's class 2B, so they may be considered in patients with acute heart failure with systolic blood pressure more than 110 millimeter mercury. IV vasodilators may be considered as initial therapy. Inotropic agents, I'll start with the contraindication. It's class 3, which means inotropic agents are not recommended routinely due to safety concerns. And one of the most important safety concerns is initiation of tachycardias like VT, polymorphic VT, and even VF or sudden death. That's very important. And it may be considered class 2B in patients with systolic blood pressure less than 90 millimeter mercury. That's very important to measure blood pressure, and accordingly we can manage with inotropic agents. Vasopressors, preferably norepinephrine, may be considered class 2P in patients with cardiogenic shock to increase blood pressure and improve vital organ perfusion. Other agents like thromboembolism prophylaxis with low molecular weight heparin is class 1 indication in patients not already anticoagulated and without contraindication or high risk of bleeding. But however, routine use of opiates, morphia or pethidine, is not recommended unless in selected patients because they might induce respiratory failure, as all you know. What about short-term mechanical circulatory support? It's class 2A in patients with cardiogenic shock as a bridge to therapy, bridge to transplantation. Of course, we don't have this in all centers, but we can use them if any. Intra-aortic balloon counter pulsation is class 3 indication. It shouldn't be routinely used in all patients because it's actually not a destination therapy. It's like a bridging to something else to be done. So they may be used as bridge to transplantation, bridge to LVAD, for example, but not routinely used in all patients, of course. What about pre-discharge and the yearly post-discharge follow-up in patients hospitalized with acute heart failure? It's recommended that all patients should be carefully evaluated before discharge. And another important thing that all oral-based therapy mentioned in the guidelines, and I think has been mentioned, and I'll mention them in a few seconds. I'll need maybe just 2 more minutes, no more. It's long item actually. So it's recommended to be initiated while the patient is in hospital. If we go to the guidelines, according to the European Society of the American College of Cardiology, we have AC inhibitors or ARBs or ARNI, we have beta blockers, we have MRA, we have ACGLT2 inhibitors, sacubitril valsartan as well. They should be all initiated according to the patient status. There are many algorithms for initiation in hospital, but before that, it's a class 1 recommendation in the ESCC and the ACC, American College of Cardiology, to initiate as low as possible, and then we can upgrade all evidence-based medications in patients with acute heart failure when they are corrected and before discharge. That's very important. This is the ACC guidelines. Those are 2 types of algorithms to initiate therapy, but I think what we are seeking for is this type, which proposed new sequencing in patients with heart failure hospitalized. So my take-home message, it's very important initially in the evaluation of patients with acute heart failure to exclude cardiopulmonary instability and exclude acute coronary syndromes, especially high-risk acute coronary syndromes. Then we can manage accordingly. Those are the 4 types or subtypes of acute heart failure presented, and we see them often in the ER. And we have to go with goals and perspectives while we are doing that, including risk factors, termination, management of comorbidities, and initiation of oral therapy before discharge. And thank you very much. Shukran jazeelan.
Thank you, Professor Teg. It's excellent as usual. I have a small comment about one of the most important criteria for successful management in hospital in patients with acute decompensated heart failure before discharge, which that to be sure that there is no residual congestion. In the last ADVOR trial, you know, with using acetazolamide, they used a very simple score, and given this score, points 10 for lower limb edema, lung ultrasound for pleural effusion, and ascites by abdominal ultrasound. Do you recommend, this is a very easy and very practical one, do you recommend to use this score before discharge?
Yeah, if we have the options to do that, so it's important to do that. However, we depend mainly actually on our clinical sense, clinical evaluation, GVB, if there is any significant lower limb edema or ascites. Lung ultrasound is very important actually, especially it's bedside actually, especially, and determining the vena cava congestion or decongestion and width of it. So they are all important parameters to initiate therapy or terminate therapy and initiate oral therapy in patients with decompensated heart failure after they are stabilized in hospital.
Thank you, Professor Ahmed Tag. For sake of time, we'll proceed to, thank you. We'll proceed to the next speaker, Professor Ahmed Adel, and he will talk about key point of heart failure in acute coronary syndrome patients.
Bismillah ar-Rahman ar-Rahim. Good afternoon, distinguished faculty and audience. في presentation مش عندي. Okay. I'm grateful to Professor Dr. Magdi Abdelhamid and the organizing committee for inviting me to this elegant meeting. In the next few minutes, I'll talk about key points of acute heart failure in acute coronary syndrome patients. And this is an important these are important points to remember and to keep in the back of our minds when we are dealing with such high-risk patients. So I gave the key points titles, and so with no further ado, I'll start with the first one. When two catastrophes meet, we have two critical situations, acute coronary syndrome and acute heart failure. Each one of them is enough to kill a patient. When we have the two combined together, this is a disaster. And that's why the in-hospital mortality is 4 to 10% in the best centers. And it's not an uncommon situation. It's a leading cause of hospitalization in patients of more than 65 years of age in the United States of America. So it's an important patient cohort that we need to address properly and promptly. We have wide spectrums of presentations, as Professor Dr. Ahmed Teg just mentioned: acute decompensation, acute pulmonary edema, cardiogenic shock, and isolated right ventricular failure, which was already addressed by Professor Dr. Karim Saeed. All of these presentations have different hemodynamic abnormalities, different clinical symptoms and presentations, and treatment methods. So we need to keep this in the back of our minds. The third key point is to prepare a checklist of causes. This is important because we need to know our enemy. There are many causes for acute heart failure due to acute coronary syndrome, like mechanical complications of myocardial infarction, ventricular septal rupture, ischemic mitral regurgitation, severe LV dysfunction because of severe ischemia, and right ventricular myocardial infarction. Each one of these has its own methods of management, so we need to keep this in mind. Ischemic mitral regurgitation is not uncommon. It is caused by papillary muscle dysfunction or chordal rupture or papillary muscle rupture. It can occur from 2 to 7 days after myocardial infarction. It occurs both in STEMI and non-STEMI. It usually affects, the posteromedial papillary muscle more than the anterolateral one, and the presentation is usually with silent myocardial infarction, mitral regurgitation, so you cannot hear the member that good, and so you may miss it, unless you do an echo, of course. And another complication is the ventricular septal rupture, which takes 3 to 5 days to appear after myocardial infarction, but it can extend up to 2 weeks. And there are many risk factors for this, like extensive myocardial damage, single vessel disease, especially the LAD, poor septal collateral circulation, the presence of a first MI, and inferior ST elevation in a patient with an anterior myocardial infarction. In the era of the reperfusion therapy, it declined from 2% to less than 2.2%, so it's better nowadays, but it's a fatal disease. And the presentation is with hemodynamic instability, with biventricular failure, and a new murmur that's heard over the chest. The fourth key point to remember is that time is crucial. We need to diagnose promptly and rapidly. We need to recognize the mechanical complications that occur late, because a patient may be hospitalized in the CCU, and then on the third day and fourth day, he develops hemodynamic deterioration. So we need to keep in our minds the causes of this, and we need to intervene promptly. Invasive assessment is mandatory. Invasive hemodynamic monitor is important to assess the vital signs of the patient, blood pressures, etc., and to closely monitor the volume stairs, like Professor Dr. Dalia just mentioned. The Swan-Ganz catheter is now abandoned. It's not needed anymore because of lack of evidence. And in the current European guidelines, they insisted on having central venous access, arterial line, continuous infusion of multiple drugs, invasive hemodynamic monitoring, percutaneous cardiac assist devices, etc. So all these emphasize the importance of having invasive and adequate and accurate monitor of the patient. The sixth key point is mechanical management. These patients need immediate interventions, whether primary PCI in case of STEMI, urgent PCI in cases of non-STEMI and unstable angina. And in this situation, we have many things to put in mind, one of which is to do the culprit vessel only, or to do anything that you find in the cath lab. And in the culprit shock trial answered this question. Culprit vessel only is much better than doing multi-vessel PCI in terms of death from any cause and renal replacement therapy, and from a composite primary endpoint of view. So we should tackle the culprit vessel alone in primary PCI. Surgical management includes tackling the acute mitral regurgitation, which has a high operative mortality if we do it surgically. Some patients with moderate mitral regurgitation can do fine with medical treatment alone and revascularization, of course, but some need intervention. And although the operative mortality is high, but leaving the patient without doing the surgery is fatal. So we will need to do the surgery for these patients, which usually is mitral repair and not replacement. This is much better. And what about transcatheter end-to-end repair? It could be hopeful in the future, but currently the recommendation is mitral repair surgery. And as for the ventricular septal rupture, it also has a high operative mortality. Doing septal repair is difficult for the surgeon because of the necrotic tissues and lack of good tissues to suture on, but it is the only way out of this problem. And device closure is another alternative by catheter if the surgery is deemed fatal. We also need to invasively and aggressively manage the patients with mechanical circulatory supports. We have different types: intra-aortic balloons, Impella, tandem heart, and veno-arterial ECMO. All of these have different principles for operation, pros and cons, but the evidence is not that good. For the intra-aortic balloon, it is negative with the intra-aortic balloon shock 2 trial. As for the Impella, there are contradicting data. The tandem heart has no RCTs at all, and the ECMO is still controversial. So that's why in the guidelines, short-term mechanical circulatory support is class 2A, and also as a bridge, only for a bridge for recovery or decision, but not for treatment. And intra-aortic balloon is contraindicated as a routine management, but only a class 2B indication if we need it for short-term stabilization of the patient before doing surgery, for instance. The seventh key point is the pharmacological considerations. Vasodilators are important. They are in the guidelines class 2B, but in the situation of acute coronary syndrome patients, they are important. In the acute mitral regurgitation and in ventricular septal rupture, they can improve the cardiac output. That is, of course, if we have a good blood pressure. Vasopressors are also important. In the guidelines, they are class 2B in the acute heart failure situation, but in acute coronary syndrome, they can be helpful in the mechanical complications if we have a low blood pressure to stabilize the patient and give him chance to do interventions or surgery. Inotropes are class 3 for routine use, but can be used in special situations. But in acute coronary syndrome, they are not preferable because they induce more ischemia because of the increasing myocardial oxygen consumption. So they are not preferred at all. There are other questions that we need to add to ask ourselves during management of patients: antithrombotic therapy and antiplatelet therapy, especially if we are going to do surgery for a patient with mechanical complications, for instance. So this is important. How can we manage those therapies in the presence of a surgery? And there's also the hepatic and the renal derangements that occur to the patients with acute coronary syndrome and acute heart failure with low blood pressure and cardiogenic shock. They usually have renal failure as well and hepatic failure. So all these can affect our decisions about different mechanical pharmacological treatments that we give for our patients. Beware of sepsis. This is the eighth key point. These are acutely ill patients. We have translocation of the GRT flora outside, increasing the sepsis. And this may increase or deteriorate the hemodynamic status of the patient even more. And all of the invasive lines and maneuvers that we do and aggressive things that we do for the patient, all these things put him at a high risk for sepsis. So it's important to monitor for sepsis during our management of patients. And the last key point is, and the risk continues. The storm may be over, but the patient is still at risk. The one-year mortality of patients with acute heart failure due to acute coronary syndrome is 25 to 30% and up to 45% in some trials. So we need to stick to a guideline medical therapy. We need to consider device therapy when indicated. We need to do proper rehabilitation and physiotherapy for the patients and to monitor them closely over the upcoming period, because this patient is still at risk and it's not over. So my take-homes, Mr. Chairman and the audience, mortality is very high in patients with acute coronary syndrome and acute heart failure. Prompt diagnosis and management is very important, and be invasive and aggressive as much as possible, because you and your patient are on thin ice. You should go on quickly and fix the problem before further deterioration, and beware that the risk is long-term. It's not only in hospital. This may extend to the next months or years. So continue monitoring the patient closely and give him the optimal medical therapy that he deserves. Thank you very much for your attention.
Thank you, Ahmed, for a very excellent presentation. I would ask about if you need for use mechanical circulatory support for bridging PCI or intervention, you need which prefer, intra-aortic balloon or Impella?
Of course, what we have in Egypt is intra-aortic balloons, so this is our only option now. But Impella can be helpful, although we don't have any data, randomized controlled trial data about it. There are small studies that showed that it's not helpful, like intra-aortic balloon is not that helpful, but we need something only for short-term support of the patient. We don't need things to stay with the patient for 2 to 3 days, only to survive the procedure. So I think it's important, the procedural success is important here, and we can rely on the intra-aortic balloon that we have here, and of course Impella if possible, but it's more invasive and we don't have it available in Egypt.
Thank you, Ahmed.
Thank you very much.
We present the next speaker, Ustaz Dr. Nabil Farrak, Professor of Cardiology at Shams University, who will speak to you today as a heavy heart syndrome.
شكرا دكتور عمرو for the presentation. طبعا I would like to يعني congratulate my dear friend brother دكتور مجدي عبد الحميد for this excellent meeting المكان الجميل ده. انا بس قبل ما ادخل فيه كان لسه قاعد مع الدكتور محمد الرملي، الدكتور حسين رزق بعت لنا حاجه كده جميله، انا بس احب اقول لكم عليها بخصوص الهابي هارت سيندروم. ان ده لقوها في شعر المتنبي. شعر المتنبي قال اتاها كتابي بعد يأس وطرحه فماتت سرورا بي ومت بها غما. يعني both broken heart and happy heart syndrome ذكر بالمتنبي من زمان. انا هقول ان هم هنا discovered امتى، انا هقول discovered امتى، انما واضح ان احنا دايما سباقين في كل حاجه حتى في الشعر. This is my presentation today and it's happy heart syndrome. I will give just small introduction that the recognition of Takotsubo syndrome as a significant cause of acute heart failure associated with specific and characteristic pattern of transient left ventricular contraction anomalies and segmental motion abnormalities, what we call apical ballooning, has risen dramatically in recent decades. It was discovered in 1990. نرجع بقى للمتنبي، شوف المتنبي اكتشفه من امتى، انما it was discovered in 1990 and classified as acquired primary cardiomyopathy in 2006. The clinical condition has been linked with various emotional and physical stressors, specifically the implication of negative emotions like grief, anger, or fear. That's why it's called a broken heart syndrome. Broken heart syndrome has well-studied diagnostic and prognostic features. Recently, emerging evidence revealed that Takotsubo syndrome can also be triggered by pleasant emotional life events, positive events in some patients, hence referring to it as a happy heart syndrome. Unfortunately, happy heart syndrome has underreported characteristics and prognostic implications, and this is the main difference between happy heart syndrome and broken heart syndrome. And these are very common pictures. Usually we see in a patient with a broken heart syndrome, and this is a picture with a normal heart compared with a broken heart. And as we see here, in stress-induced heart failure, one part of the heart moves in a ballooning pattern, usually the apex of the left ventricle, and it resembles typical ceramic Japanese octopus. الرسمة اللي هي اللي هناك دي تريب اللي هو اللي بيصطادوا بيه الاوكتوبس في اليابان، بيبقى نفس المنظر بالظبط، هو منظر البروكن هارت. This is a broken heart syndrome. Clinical presentation of both broken heart and happy heart syndrome are the same. So when we are talking about clinical presentation, we are talking about both broken and happy heart syndrome. And the most common symptoms of this Takotsubo syndrome, including both broken heart and happy heart, are chest pain, dyspnea, and syncope. Some patients may present with symptoms and signs of acute heart failure. Not only that, but also with tachyarrhythmias, bradyarrhythmias, sudden cardiac arrest, and sudden cardiac death or severe mitral regurgitation. Also, there may be symptoms and signs of transient ischemic attacks or stroke-like presentation. So not only the heart is affected, but also the brain can be affected. Approximately 10% of patients with stress cardiomyopathy develop cardiogenic shock. When we are talking about stress cardiomyopathy, we are talking about both broken heart syndrome and happy heart syndrome. According to the National Institute of Health, Takotsubo syndrome can also be fatal. In hospital complications such as death, pulmonary edema, cardiogenic shock, or stroke, and long-term mortality rates are similar in case of positive means a happy heart syndrome, and negative broken heart syndrome emotional events. And this is the ECG pattern in both broken heart and happy heart syndrome, can present with a picture like acute coronary syndrome, chest pain with ST elevation in the ECG, and also can present with tachyarrhythmias or bradyarrhythmias, and these tachyarrhythmias can be atrial fibrillation, for example. And this is the angiography and echocardiography of patients with broken heart syndrome. And we can see during systole, there is ballooning of the apex. It's very clear here in both angiography and in echocardiography. So what are the main differences between broken heart syndrome and happy heart syndrome by angiography or by MRI? If we look at a broken heart syndrome, we are talking about apical ballooning. But if we look at a happy heart syndrome, we are talking about mid-cavitary or mid-ventricular ballooning, like the second picture here. This is the commonest picture of a happy heart syndrome. Again, broken heart is apical ballooning. Happy heart is mid-ventricular ballooning. Sometimes segmental wall motion abnormalities with ballooning affect the base of the heart, or sometimes it's focal. So it's totally different. The pattern of happy heart syndrome is totally different from that with broken heart syndrome. How can we diagnose both broken heart and happy heart syndrome? Two important criteria and two main criteria needed for the diagnosis. First, there's a transient left ventricular wall motion abnormalities in the form of either apical ballooning or mid-cavitary or mid-ventricular ballooning. Apical ballooning in broken heart, mid-cavitary ballooning in happy heart syndrome. This is number one. Number two, these segmental wall motion abnormalities should be in the absence of a condition obviously explaining this wall motion abnormalities, in the absence of coronary artery disease, in the absence of hypoperfusion, myocarditis, or some drug toxicity. Added to this help in the diagnosis, the presence of a characteristic ECG change. And this characteristic ECG change could be changes like acute coronary syndrome, the picture we see before, or tachy or bradyarrhythmias. This is the ECG characteristics of Takotsubo syndrome, either broken heart or happy heart syndrome. This picture of acute coronary syndrome is associated with mild to modest elevation in cardiac troponin. There is no excessive rise of cardiac troponin in patients with Takotsubo syndrome like other pictures of acute coronary syndrome, and this differentiates Takotsubo syndrome from the classic picture of acute coronary syndrome, in addition to the normal coronary angiography and the left ventricular pattern of segmental wall motion abnormalities. What are the treatment can we give to a patient with Takotsubo syndrome? Definitely, it is a supportive treatment based on the presentation, whether heart failure, whether arrhythmias, whatever the presentation. So it's supportive treatment because actually this syndrome is a transient disorder. All of this can be reversed back to normal after treatment. And this, this is an important study. It's a German, Italian, Spanish Takotsubo registry. In this registry, patients were enrolled and categorized based on the type of stressor. Patients with pleasant emotional events or positive emotional events, called happy heart syndrome, were compared to those with negative emotional events like grief, anger, or a broken heart syndrome. And this is registry included more than 2,400 patients. They found that the prevalence of pleasant emotional trigger or happy heart syndrome was only 1.5 of the all cases of Takotsubo syndrome. And compared with a broken heart syndrome, patients with happy heart syndrome were more frequently male. Broken heart usually in postmenopausal women, but this in males. Both has low estrogen, so it's related to the stress and hormonal effects as well, and had a higher prevalence of atypical ballooning pattern. Atypical ballooning pattern, it's a mid-cavitary or mid-ventricular ballooning in happy heart syndrome, in contrast to apical ballooning with a broken heart syndrome, particularly طبعا mid-ventricular. Unfortunately, in hospital complications including death, pulmonary edema, cardiogenic shock or stroke, and long-term mortality rates were similar in both happy and broken heart syndrome. What is behind this syndrome? What is the pathophysiologic mechanism behind this syndrome? It's a brain-heart interaction. And this brain-heart interaction with sympathetic overdrive and catecholamine, epinephrine, and norepinephrine surge. This surge was triggered by acute emotional stress, and this acute emotional stress could be positive stress and could be negative stress. Positive stress will lead to a happy heart syndrome. Negative stress will lead to a broken heart syndrome, and sometimes by physical stress. Emotional stress and physical stress can lead to Takotsubo syndrome, either a broken heart or happy heart syndrome. What are the similarities and the main difference between these two syndromes? Let's go to this figure. We can find that the main similarities between these two syndromes, number one, the clinical presentations, as I said before, either chest pain, dyspnea, syncope. Number two, the ECG changes. Both can present by acute coronary syndrome, tachyarrhythmias, bradyarrhythmias, as well as similarity in the rates of hospital complications as well as long-term mortality rates. The main difference is that happy heart syndrome is triggered by positive emotions. It is prevalent in males. And third, it is non-apical ballooning pattern. It is a mid-ventricular or mid-cavitary ballooning. And it is the rarest type of Takotsubo syndrome. It represents only 1.5 of all cases of Takotsubo syndrome. In a broken heart syndrome, it's triggered by negative emotions like anger, fear, and it is prevalent in postmenopausal females, again, with low estrogen. That's why it can be attributed to the low level of estrogen in these females. Characterized by apical ballooning pattern, and is the commonest type of Takotsubo syndrome. So this is a quick takes as regards this syndrome, that happy heart syndrome, unlike broken heart syndrome, is provoked by positive life events. Happy heart syndrome is rare, only 1.5 of all Takotsubo syndrome, more commonly seen in men, unlike broken heart syndrome, which is commonly in postmenopausal women and more likely to present with atypical non-apical ballooning. Short and long-term outcomes were similar to patients with broken heart syndrome based on the GIST registry I mentioned before. Happy heart syndrome is a rare type of Takotsubo syndrome characterized by a higher prevalence of male patients with transient wall motion abnormalities such as atypical and non-apical ballooning features, in contrast to broken heart syndrome, mid-ventricular ballooning compared with case of broken heart syndrome. Short and long-term outcomes were similar to patients with broken heart syndrome. Thank you for attention.
Thank you, Professor Nabil Farag, for this comprehensive talk. I would like to ask about the usual effect of excess stress, increase in the sympathetic overload on the heart. It will increase the overall contractility. Why in such patient this happens?
This is very, very important questions. And if I have a slide, but I didn't show it, why this pattern and why this area of the ventricle is affected and other areas are not affected? It's related to sympathetic overdrive and sympathetic surge and the nerve supply of the heart itself. It is different in patients with positive emotional stress than patients with negative emotional stress. In females or postmenopausal women, the nerve supply is different. That's why it's take the shape of ballooning. In males, it is take another shape. This is related to the distribution of the sympathetic nerves to the heart, and that's why we have this shape.
I think also there may be a redistribution of the beta receptors.
Yes,
at the base of the myocardium more than in the apex.
وفي حاجه كمان converting the positive inotropes of sympathetic overdrive على الفنتركل into negative inotropes. ففي الاريا دي بتبقى negative inotropes مش positive inotropes، عشان كده بيحصل ballooning.
Thank you, Dr. Dr. Ahmed.
Dr. Nabil, thank you for this excellent presentation, as usual, sir. The question here, you said, sir, that Takotsubo or happy heart syndrome, emotional stress or physical stress?
Yes.
How can I differentiate in physical stress, mainly I think for acute coronary syndrome or this direction? Emotional, I go mainly from the history. I will know it is happy or
yes.
broken heart syndrome. Physical here, I feel it's the gray zone. I can't decide.
Yes. How can we differentiate between both?
Yes, sir.
Definitely, the patient will come with a picture like acute coronary syndrome. So we can, first presentation, you will not be able to differentiate. Maybe the age, maybe it's a young male or something like this. But first, you can differentiate. The only differentiation is, as I said, the pattern of ballooning or the pattern of the segmental wall motion abnormality we find either in the echo or in the angiography. In addition, usually this patient has a normal coronary angiogram, and this is very important.
Thank you, Professor Nabil, and thank you for